Teman-teman, sebelum melanjutkan video ini, terus dukung channel kami untuk berkembang dengan cara mensubscribe channel ini. Terima kasih.
Hi guys, welcome back with me Agung Hariwibowo in this channel. Now we will talk about a diagnostic strategy in acute encephalopathy and encephalitis in infancy. Some infectious encephalopathy syndromes have been defined based on radiologic findings in addition to clinical features. In this section, I have reviewed 3 infectious encephalitis in encephalopathy syndromes in which neuroimaging, especially magnetic resonance imaging or MRI, is essential for diagnosis. Acute encephalopathy with biphasic seizures and late reduced diffusion or AESD is characterized by a biphasic clinical course, that is, a prolonged febrile seizure or early seizure on day 1 followed by late seizures, cluster of complex partial seizures on days 4 up to 6. MRI shows no acute abnormality during the first few days, but reduced diffusion in the frontal or frontoparietal subcortical white matter on days 3 up to 9. AESD is the most common encephalopathy syndrome in Japan. However, it has been rarely reported from countries other than Japan. Exotoxicity injury with delayed neural death is hypothesized as a possible mechanism based on MR spectroscopic findings. Clinically mild encephalitis or encephalopathy with a reversible splenial lesion is the second most common subtype in Japan, which is radiologically characterized by a reversible splenial lesion with homogeneously reduced diffusion. The neurologic syndromes consist of delirious behavior, followed by consciousness disturbance and seizures, which completely resolve within a month. The reason for the transiently decreased diffusion is unknown. However, some pathomechanisms have been postulated, including intramyelinic edema and interstitial edema in tightly packed fibers. Acute necrotizing encephalopathy or ENE is observed in children in East Asia who show consciousness disturbance, seizures, and delirious behavior. ANE is the third most common encephalopathy syndrome in Japan, although the frequency of ANE seems to have become reduced recently. Bilateral symmetric lesions in the thalamus are essential for the diagnosis of ANE, which longitudinally show a hemorrhagic component and cystic degeneration. Electroencephalopathy or EEG is considered to be successful or to be useful for diagnosis and prognostication in children with acute encephalitis and or encephalopathy AE. Several EEG abnormalities have been reported in children with AE. Generalized unilateral or focal showing is frequently observed in children with AE. Low voltage is seen in severely affected children. Increase in fast activities is characteristic in anti-NMDA receptor encephalitis. whereas decrease in fast activities is sometimes seen in children with acute encephalopathy with biphasic seizures and late reduced diffusion. Although periodic discharge, paroxysmal discharge, and episodic transients have been reported in various types of AE, they are considered to be non-specific findings. Ictal changes can be observed in some children with AE, especially in those with acute encephalitis with refractory, repetitive partial seizures and hemorrhagic shock and encephalopathy syndrome. Continuous EEG monitoring has recently been applied to critically ill children with impaired consciousness. Electrographic seizures or electrographic status epilepticus is not infrequent in such children and can be overlooked without continuous EEG monitoring. Several studies have revealed that seizure burden and abnormal background activities may be related to mortality and poor neurologic outcome. Continuous EEG monitoring is considered to alter clinical management in seriously ill children. However, resource requirements are a limitation of continuous EEG monitoring. Quantitative EEG such as amplitude integrated EEG has also been applied to seriously ill children with impaired consciousness. The main advantage of quantitative EEG is easy application and interpretation of EEG activities. Therefore, monitoring with quantitative EEG may be used as a surrogate for continuous EEG monitoring, although several limitations are present. Evidence of useful of EEG is still insufficient. The diagnostic and prognostic value of EEG should be confirmed by prospective multicenter studies in near future. Acute encephalopathy due to cytokine storm has markedly elevated pro-inflammatory cytokines in the serum. Children with hypercytokinemia often have systemic inflammatory response syndromes or SIRS. These findings are useful for diagnosing the type of the acute encephalopathy, hyperglycemia, the presence of hematuria or proteinuria, and serum elevated levels of aspartate aminotransferase, tumor necrosis factor alpha, TNF alpha, cytochrome C, interleukin 6 or IL-6, soluble tumor necrosis factor receptor 1, STNFR1, AL10, tissue inhibitors of metalloproteinase 1, TEMP1, soluble CD163, and high mobility group box 1, HMGB1, have been reported as markers indicating poor outcome of the type of the acute encephalopathy. It is often hard to distinguish acute encephalopathy due to excitotoxicity from prolonged febrile seizures without neurological sequelae during the initial stage. The CSF2 protein S100B, vicinin-like protein or VELEP1, and IL-6 have been reported as biomarkers for diagnosing the type of the acute encephalopathy at the initial stage. The serum elevated matrix metalloproteinase 9 MMP9 levels and MMP9 or TAMP1 ratios have been reported as markers indicating poor outcome of the type of the acute encephalopathy. Thank you for this section. If you have any question, please fill the comment. Thank you.